talk. Special thanks goes to Dr. Nayar and the whole team, the organization. I know them all personally. My talk is going to be a broad spectrum about the female fertility nutrition, like Dr. Sabina mentioned about male infertility. We all know roughly around 50% of the patient couples are the cause is female infertility, and WHO has performed a multinational study to determine the female fertility etiologies. 25% have ovarian disorders, 15% have endometriosis, 12% have pelvic adhesions, 11% have tubal block, and other tubal abnormalities, and 7% hyperprolactinemia. Idiopathic is 19%. In male infertility, idiopathic is almost 30 to 40%. In female infertility, idiopathic is 19%. When we were having lunch here, one of the colleagues asked me that what is the causes of infertility I see in my clinic, and I was telling them for us, the tubal pathology is a number one cause, and number two cause is the ovarian disorder, which includes PCOS. And we were discussing that the incidence of PCOS is increasing because of the lifestyle disease, lifestyle problems, and the changes in the oxidative stress, which is increased. So all this is adding on to infertility. How old is too old? I want all of you to see it. You can see it. A woman is born with almost 1 to 2 million of eggs when she is born. And over a period of time, all these follicles undergo atresia. That is how the ovarian reserve is decreasing. The follicles undergo atresia. And although all the follicles, almost 400 to 450, are the ones which are ovulated. It will be ovulate, this one. So by the time reserve reach puberty, there are 300,000 follicles, and they keep on decreasing, finally they finish. The stage of follicogenesis, we all know, we have a gonadotropin independent stage, when the follicles are going with respect to gonadotropin, from primordial follicle, primary follicle, prenatal follicle, then the gonadotropin dependent, which lasts for almost 14 days. The possible mechanism for the origin of premature ovarian insufficiency or generally, either woman is born with less number of primordial follicles, or the rate of atresia is increasing, and there is a altered follicle maturation. All these three causes are causes of the follicular mechanism, which we are going to see. What we are focusing basically on faulty ovum. If you look at it, what is the cause of faulty ovum? Number one is oxidative stress. Then is oocyte maturation failure, poor oocyte quality, poor ovarian reserve, and finally anovulation. We are going to say a poor ovarian responder, that is a very important cause for us. 9 to 24% of the women are having this problem, and it is the most challenging task in reproductive medicine. When a day in and day out we see women with a very poor ovarian reserve, and we are always scratching our head how to go about how to produce a follicle in such a woman. And the diminished ovarian reserve is the most important cause of this poor ovarian responder. And diminished ovarian reserve, either the woman is born with pure eggs, or she is losing them more quickly than the average. Over the time, the egg is ovulated more damaged than the average. Look at the picture, they show you that the white circle represents the normal eggs and the grey circle represents the abnormal eggs. As the woman is having diminished ovarian reserve, either she is born with less number of eggs or lose them more frequently, or over a period of time the eggs accumulate more damage. So we have more damage to the eggs, the functional ovarian reserve is also poor. Oocyte maturation failure. Approximately 8 to 12-15% of all infertile patients produce at least one meiotically incompetent oocyte. And 0.1 to 1% of women may have defective oocyte maturation. If any one cohort, if more than 25% oocyte are immature, then the successful fertilization with clinical pregnancy rate is generally reduced. That is what my embryologist always say. When I do a womb pickup, I give him the oocyte. At the end of the screening, he said, Dr. Nayar, 30% are immature. So, there with 30% of the oocytes are immature, we know that the chance of pregnancy in such patient is already reduced at the time of womb pickup. The oocyte maturation arrest can occur because of dysfunction at the molecular level, resulting in the incapacity of oocyte to progress, and there can be error in the signaling, aberration, and chromosomal hospital formation. You can look at this. On the left side, there is germinal vesicle. Then is M1 with one oocyte, which is immature. The last one is the mature M2 oocyte. Poor oocyte quality can be because of complete meiotic maturation. You can support fertilization and embryonic development, and it can lead to a successful live birth. The free radicals, we are going to talk about it. They are changing the microenvironment and deteriorating oocyte quality. And deteriorating oocyte quality is a major problem in infertility. These are the signs of the egg quality, poor egg quality. Finally, anovulation is 30% of women are having anovulation, and that is also causing a poor oocyte quality. We all know whenever we have a PCO patient, we get them, we get number of oocyte is very high, and the quality of oocyte is bad. That is one of the reasons that when we stimulate PCOS, we are very much worried that what we are going to be the end result in such a woman. The defective follicogenesis, for successful follicogenesis, you need a healthy inflammatory response, and if you have a aberrant inflammation, which can be associated with oxidative stress, and it can be a bad thing for oocyte quality. Can oxidative stress lead to infertility? Yes. If you look at this, there is an excessive ROS in the follicle, and it will increase follicular fluid antioxidant difference, damage DNA of the oocytes, and finally causing female infertility. So basically it causes protein oxidation, and it can hinder the trophoblast division required for development of pregnancy. Defective follicogenesis, oxidative stress can cause, like I mentioned, DNA damage to the follicular microenvironment, and decrease availability of antioxidant. The effect of oxidative stress on female reproductive system, if you look at this, right from oocyte, if there is a bad effect on oocyte, then the ovary, it is having a bad effect on ovary, it is having bad effect on fallopian tube and uterus. So all the system in a female reproductive health, they are all affected by the oxidative stress. You cannot say that oxidative stress is only acting on oocyte. It is acting also on the ovary. It is acting on the fallopian tube. It causes ciliary dysfunction and risk of ectopic pregnancy. It is acting on the uterus also, prevent implantation, endometriosis, preeclampsia, abnormal presentation. All these are the features which we are having the oxidative stress as the basic etiology. These are the common barriers in the journey of motherhood. If you look at, one is a better ovarian response, then number 2 is a reduced oxidative stress, number 3 is helping ovulation induction, number 4 is better oocyte quality, high fertilization and pregnancy rate, improved oocyte retrieval, and improved IUI and IVF outcome. So all these are generally the common barrier in the journey of motherhood. And the emerging role of nutraceutical, to overcome these common barriers, we are using the various nutraceutical available to us. We are again going to go back some of the same nutraceutical which are being used in male infertility, and the same are being used in female infertility, like melatonin is a free radical scavenger, and it increases beta-2 metaphase 2 M2 oocyte count and grade 1 embryo ratio. There was improving the oocyte and embryo health. This is how the melatonin acts. It decreases the DNA damage, it increases the mitochondrial function, and lipid perioxidation is also reduced. All this is helping in getting us a good quality oocyte. And melatonin improves the oxidative balance and improves the oxidative oocyte quality. This was a publication published in 2011 in Journal of Assisted Reproduction, and the main significance is that the number of retrieved oocyte is increased, and patient benefit from melatonin in improving the oocyte and embryo quality. Next is coenzyme Q10. Dr. Sabina already mentioned about it. It is the only liquid soluble antioxidant in human, and it reduces the DNA damage in the ovaries. The CoQ10 is reducing ubiquinol during or after absorption in the gut. So the ubiquinol has a greater bioavailability than the ubiquinol. We have to remember this thing that when we want to give CoQ10, we should be able to use ubiquinol, which is more bioavailable. This is how the CoQ10 acts. CoQ10 is an essential component of mitochondrial electron transport and ATP production. The human oocyte has the largest number of mitochondria of any cell, approximately 2:10 to the power 5 population. 2 million mitochondria are present in a single oocyte. When you look at a sperm, in the mid piece of the sperm, normally there are 70 to 80 mitochondria only. In oocyte, almost 2 million sperms are there, 2 million mitochondria are there. And functional status of mitochondria contributes to the quality of oocyte. Decrease in CoQ level is commonly observed in individuals in the late 30s and 40s, and age-related decline in fertility. This is again coenzyme Q10 in fertility. It is acting on the oocytes, it is acting on the granular cell, and it is acting on gene related to oocyte quality and metabolism. All this action leads to a enhanced quality of oocyte and granular cell. That is the benefit of using CoQ10. This is a publication in Reproductive Biology and Endocrinology, published in 2018. And the result of this study was that the gonadotropin requirement is reduced and increased peak E2 level is there. Coenzyme Q10 is also reducing the post-meiotic aneuploidies. That whenever you give CoQ10 to a patient, the risk of aneuploidy is reduced. So the transition from GB granular vesicle, GB to metaphase 2 oocyte, and reduced aneuploidy rate is because of addition of CoQ10 in an IVF media in an older age group. So whenever we have a older age group patient, we should give them CoQ10 because we can reduce the post-meiotic aneuploidy rate in such a patient. This is another publication in 2020 that does coenzyme Q10 supplementation improve fertility outcome in women undergoing assisted reproduction? Yes, the oral supplementation can, the mean number of mature oocyte and ovulation rate is improved when you give CoQ10. And CoQ10 can act as a protector of ovarian reserve and increase the clinical pregnancy rate. That is N-style cysteine, NAC. It can improve sensitivity of ovaries to the exogenous gonadotropin and promote the oocyte development capacity. And it is inducing or augmenting ovulation in polycystic ovarian patient. The publication for NAC was also there in 2022, and they say the NAC treatment group is giving a high quality blastocyst, and follicular fluid glucosamine content was also higher. So once you give NAC, you are definitely going to get benefit from using this NAC. And if you look at the results, there is diminished ovarian reserve and decreased developmental competence of oocyte because of the age, because of the poor quality of oocyte with the age, and there is no follicular development. NAC is beneficial for follicular development and increasing intracellular GCS, which is the most popular antioxidant that can reduce the reactive oxygen species. So conclusion is that combination NAC and gonadotropin treatment can improve the ovarian response. L-arginine, we are giving it day in, day out, and it also improves the follicular growth and probably the oocyte quality. Adjuvant L-arginine for IVF patient, this publication, Reproduction in 1999, little older publication, but you have when you give L-arginine, you have the increased number of oocytes. And nitric acid is a regulator of ovarian function, and nitric oxide acts as a vasodilator, increasing the permeability of follicular epithelium. In conclusion, when you give L-arginine, it can improve the ovarian response, endometrial receptivity, and pregnancy rate. Resveratrol. See this compound, resveratrol. This is an anti-aging compound which is being marketed, and this is a new thing which is there in the market, and it has beneficial effect on follicular pool and oocyte quality, and it is available with the trade name of Genantentum. Believe me, I listened about this product about 4 or 5 years back in ASRM, and people are ladies who are older age group and who want to have their own babies from their own side. They are taking this thing like left and right. It is supposed to be rejuvenating the ovaries, and the dose is 150 milligram. You combine with folic acid 400 and vitamin D and vitamin B12. The mean number of fertilized good quality oocyte is significantly increased. So maybe this is a drug for future. Resveratrol improves the follicular microenvironment and improves the oocyte quality and pregnancy outcome. Omega-3 fatty acid supplementation and fertility, we all know omega-3 fatty acid is an inexpensive modifiable factor to improve the fertility, and the effect of diet and nutrition intake, like nutrition intake may be important modifiable factor, and when we talk about nutrition intake, we are talking about vitamin C, vitamin D, and vitamin E. Vitamin C and vitamin E are some of the most potent antioxidants available to us, and they are one of the most cheapest available to us. Vitamin C tablet doesn't cost us more than maybe 10 rupees, similarly vitamin E. And we have more higher expensive brand of antioxidant available in the market. This is what generally I give to all my patients, vitamin C and E, as a supplementation when they want to come for fertility treatment. Improving oocyte health and quality, you can add selenium, chromium, zinc. Antioxidant, you can again add selenium or zinc. Now we are coming to this broad spectrum female fertility nutrition. This is the linear F. It overcomes all the barriers. The barrier which I have mentioned earlier on, the one number is better oocyte, ovarian response, the oxidative stress is reduced, helping ovulation induction, better quality oocyte. So linear F is overcoming all the barriers. If you look at it, it has all the ingredients which I talked about it, all the nutraceutical like melatonin, arginine, N-acetylcysteine, CoQ10, resveratrol, alanine, DHA, vitamins and minerals. And each one of them is acting on a specific role in this whole female reproductive health, either acting on better ovarian response or reduce oxidative stress, helping ovulation induction, better oocyte quality, high rate of fertilization and pregnancy. That is what we are looking for, and improve oocyte retrieval and improve IUI and IVF outcome. When you look at it, the composition of linear F which is available to us, melatonin is 3 mg, NAT is 600 mg, ubiquinol, that is CoQ10 is 100 mg, vitamin C is 50 mg, vitamin D is 6 mg, vitamin E is 5 mg, L-arginine 1000 milligram, and vitamin B12, B6, B3, lycopene is 4 milligram, and alpha-lactic acid is 500 milligram, chromium, selenium, zinc, DHA is 200 milligram, and resveratrol is 15 milligram. Compared to the linear graft, which has all the ingredients in one formulation, we have other formulations available in the market which are being mentioned on this slide side, but most of them are not containing all these nutraceuticals. They contain few of them. So that is the advantage of using linear graft when we are using as a supplementation, that we are able to provide all the nutraceuticals to our patient. This is basically the dosage. You can use it once per day, and it can be given in the night. Patient can take this sachet in the night, and basically it is improving the ovulatory disorders and unexplained infertility. It will result in a better oocyte, better ovarian response, improved number of mature oocyte, reduce the oxidative stress, better oocyte quality, helping ovulation induction, high rate of fertilization, and improving the IVF IUI outcome. That is the advantage of using this linear graft. Thank you very much. If you have any questions, please.